Yeah, okay. So we haven't got many people in the room here today. I guess that's Walkout Wednesday with the bus and train strikes. So lots of people working from home today. It looks like we're starting to get people filtering in online to join us. So we'll get started in a second. Welcome everyone that has made it in the room today, and those of you that have joined us online as well. So we've got two research-based talks today. So first up is Muzna Nanaa, and secondly will be Nikita. So two different topics, breast first, followed by prostate. So Muzna has been with us since May 2021, working with Fiona, and is a radiologist, completed training in Aleppo in Syria, and is with us here on a CARA fellowship. So that's for a Council for At-Risk Radiologists. So that allows radiologists that are working in at-risk places around the world to work in safer environments, and has been very active working on particularly automated breast ultrasound, I believe, and contrast-enhanced spectral mammography, and also involved in some of the trials that are ongoing, like such as BRAID. And today you're going to be talking to us with a more of an AI theme, I believe. So I'll hand over to you. So AI prompt accuracy for interval cancer detection in screening mammography. Thank you.
Thank you, Tristan. And I'm glad to be here to introduce this work today. As Tristan said, I am a radiologist from Syria. I am a graduate from University of Aleppo in Syria. And I have received a PhD in 2019 in breast imaging, breast cancer screening. So for the talk today, this is to show the accuracy of AI prompt to localized interval cancer on screening mammography images. Obviously, this was undertaken with Dr. Sarah Hickman and the team under supervision of Professor Fiona Gilbert. Thanks. Yeah, our disclosures. The aim of this study was to retrospectively evaluate the performance of AI to detect interval cancer on screening mammography images, as well as to assess how accurate AI prompt location is. So the methods, this retrospective study used data from the CC Media study, which holds anonymized images from the Cambridge and Norwich breast screening program. An enriched data set of 514 interval cancers and 1,548 normal cases were obtained between 2011 and 2018. A consensus panel of consultant breast radiology experts classified interval cancers into either normal or benign, true negatives, uncertain cancers with minimal signs of malignancy, and suspicious false negatives. In case of bilateral interval cancer, a case was split into two cancer cases. Cases where cancer region was not included on both views were excluded. A flow chart shows the initial number of interval cancers and cases that were ruled out. One AI system was tested using this data set. This output provided cancer risk scores on a scale between 1 to 10. Breast density classification was also provided by the same AI system. For the AI scores, different score thresholds were used to determine the number of cases for recall by AI. For example, one of the thresholds, 6.8, was used was chosen to deliver 96% specificity on this data set. As this represents the average recall rate of 4% in the UK breast screening program. So where there is a score above the threshold, positive cases were examined for the location level, at the location level by a radiologist with 7 years of breast imaging experience. Radiant DICOM viewer was used to review AI prompts, and dedicated workstation was used to review screening and diagnostic images. When there is uncertainty about cancer location, a consensus reading was formed with a radiologist with more than 10 years of breast imaging experience. Turning to look at interval cancer dataset characteristics, dense breast is observed in more than 80% of cases. About 46% of cases were diagnosed within the 3rd year following screening. Up to 90% of interval cancers were invasive cancers. These invasive cancers were predominantly grade 2 and grade 3 cancers. Moving on to some cases, this is a 56-year-old female who was diagnosed with this 35mm grade 2 invasive mucinous carcinoma in the 3rd year following screening. This interval cancer, classified as normal, was not detected by AI. This interval cancer, diagnosed within the 3rd year following screening, it is 17mm grade 1 invasive ductal carcinoma. It is classified as cancer with minimal signs of malignancy, was localized accurately by AI on the MLO view at 96% specificity. This was also localized on the CC view accurately, but at lower threshold level. This is grade 2 invasive lobular carcinoma, was diagnosed in the 3rd year following screening. This interval cancer, classified as suspicious, was accurately localized on the MLO view at 96% specificity, along with false positive prompts provided on the CC view. This was also localized on the CC view, but at lower threshold level. So here is the results. At 96% specificity, AI prompted 23.5% of cases. 90% of these prompted cases were prompted on the correct breast side, and 76% were prompted in the correct breast location. The highest score, AI score, was given to the cancer area in 97% of cases, and cancer was accurately localized on both views in just 31% of cases. In case cancer was just localized on one view, there is a higher possibility for cancer to be localized on the MLO view than on CC view. AI detected and accurately localized 12.6% of true negatives, 46% of cancers with minimal signs of malignancy, and 50% of false negatives. When it comes to the localization accuracy, we can see that all wrongly localized cancers were from cancers classified as normal with no signs of malignancy, visible signs of malignancy. This is a comparison between interval cancer dataset and normal dataset in terms of the number of prompts, number of prompted cases, and the number of false positive prompts. For both groups, the number of false positive prompts per case in dense breasts was twice that of in fatty breasts. At lower threshold levels, the performance of AI shows higher cancer detection rates. But with more false positive prompts for cancers and more false positive recalls of normals. AI detected and accurately localized a greater proportion of cancers diagnosed within the first year after screening, higher rates of cancer, invasive cancers at 19% than non-invasive cancers at 8%, similar percentages of grade 1, grade 2, and grade 3 cancers. Grade 1 detected cancers by AI were diagnosed at smaller tumor size than higher grade cancers. AI detected and accurately localized a greater proportion of node positive cancers and a greater proportion of luminal cancers than HER2 enriched and triple negatives. The limitations of this study, retrospective study design, there was no interaction analysis between AI and readers' performance, testing only one AI system. Conclusions, AI can identify 23.5% of interval cancers with accurate localization in 3/4 of cases at 96% specificity. By lowering the specificity, more interval cancers can be detected, but at the penalty of increasing recall rates. Additional imaging techniques may be required to assess cases where AI has a high score, otherwise the case may be wrongly dismissed as normal. Thank you for everyone contributed to this work and for everyone on the slide.
Yeah. Okay, thank you. We'll just quickly get the slide deck changed over in the background. And while Nikita's doing that, I can introduce him. So the second research presentation is with a prostate theme. So Nikita Sushentsev is very well known within our department here on level 5 in radiology. He's a final year PhD student working under the supervision of myself and Ferdia Gallagher. And he's done outstanding work, particularly with the Hyperpolarised projects for prostate, but also in the field of AI and radiomics in our active surveillance population. This is building on the work that was published last year, about a year ago, and also was featured in the Sunday Times in the lead health article in February last year. So hyperpolarized MR of the prostate and the clinical applications of that. Nikita is by background a medic and is looking to apply for radiology next year. We're going to encourage him to apply in Cambridge. So hopefully that goes through and he'll be very well known to you in the clinical side as well as the research side. So I'll hand over to Nikita.
Thank you, Tristan. Thanks, Fiona, for your introduction. Is that all right? Sorry. All right. Thanks again. Thanks, Tristan. Thanks, Fiona, for giving the opportunity to talk at the forum, finally, after all those years. That's great. And we've got an evening of hormone-dependent cancers today, breast and then prostate, which is probably not a coincidence. So let's talk about some hyperpolarized MR of prostate cancer indeed. But let's start just with the clinical overview of what prostate cancer is about and what is the most pertinent clinical challenges in this disease. Well, prostate cancer is incredibly common, and it affects more than 52,000 men in the UK every year. Now, roughly 15% of those present with low-risk disease. And normally, it's a disease that's not even seen on MR. It's diagnosed on biopsy. And for those patients, active surveillance is a well-known, well-established, safe, and recommended method of management. And then 50%, unfortunately, present with high-risk disease, for which multimodal therapy is again accepted and not really debated. But then 35% of men harbor what we call intermediate risk disease. And for those, the jury is out. Not in all cases, but in the majority. You can have them on active surveillance, or you can start with treatment straight away. Now, the problem is that whatever you do, approximately a third of patients in both groups will develop adverse outcomes. They'll either progress on active surveillance or they will show biochemical recurrence after treatment. So distinguishing the tigers from pussycats, as we put in that Sunday Times article, is really the dominant clinical challenge in the first diagnosis setting in that disease. Well, let's take a step back and think, how can hyperpolarized MR and molecular imaging help with that? Well, we can try and distinguish these tumors based on their metabolism. And we know that aberrant metabolism in the cells is a hallmark of cancer. So as of 2022, it's officially an established hallmark. It's not an emerging hallmark as it was previously. So we're all sorted here. So we can try and image that. And when we think about those deregulated cellular metabolism in cancer, we immediately think about this chap called Otto Warburg, who showed that tumors, for whatever reason, do produce more lactate, even when there's enough oxygen within the media. And then that's what hyperpolarized MR with pyruvate as its substrate is poised to do. So that's the machine that we have downstairs in the MR, and then we also have the second one in the WIBIC here. And what we do during the procedures, we inject hyperpolarized pyruvate intravenously. It enters the cell that expresses MCT1, and in prostate cancers, I'm going to show these are the epithelial cells. These are the actual tumor cells, and not the stromal cells, not immune cells or anything else. It's the actual tumor cells. And then under the influence of LDH, lactate dehydrogenase, the enzyme, pyruvate is being converted into lactate, and we can visualize this conversion. We can track at which speed it occurs, and we can quantify how much pyruvate went into the tissue and how much lactate was formed. So that's the background of how hyperpolarized MR in general works, but we are in Cambridge, and you've heard this hundreds of times before. So let's start with prostate. Well, actually, the first ever clinical, first translational study using hyperpolarized MR in patients was published in prostate. And it was done by a group from UCSF back in 2013. And that paper showed that compared to the benign prostate, areas of prostate cancer that were proven on biopsy showed indeed increased lactate production as was expected. Well, then the same group demonstrated that you can also see the increased lactate production in prostate cancer metastases that were found in the bone and in the liver. And then a group from MSKCC slightly later demonstrated that you can distinguish benign prostate from really low-grade disease from very high-grade disease. So effectively, if you look on top of the slide, so left from right, but not really in the middle, which we'll get back to in a second. And then the group from UCSF demonstrated that you can see significant changes in lactate labeling following hormone therapy and immunotherapy. And again, we'll get back to that closer to the end of this presentation. So let's focus on the clinical challenge that we've described at the beginning of the presentation. So, all right, we can detect tumors using hyperpolarized MR. Well, you can argue we could do that with conventional proton MR. And we can tell the difference between very low risk and very high risk, which again, we can reasonably do with the standard MR. So how we try to address this problem. So we set up the hyperpolarized MR facilities here in Cambridge for prostate and managed to prospectively recruit 10 patients with 15 lesions, most of whom were in fact patients with intermediate risk cancer, which you would expect from a surgical population. They all underwent hyperpolarized MR and we measured lactate SNR as a measure of tumor glycolytic activity. And they all then underwent radical prostatectomy so that we could get the whole prostate out and assess what was happening there at the biological level and correlate that with what we saw on imaging. So the very first thing that we did was obviously look at the images and compare the proton MR to hyperpolarized MR. And in this particular case that you can also find in the paper, well, on the first look, you can clearly see a very well-defined lesion in the left peripheral zone of the prostate. It's PIRADS 5. It shows a low T2 signal, low ADC signal, also high diffusion signal if it were present here, and then it shows avid contrast enhancement. Well, then on hyperpolarized MR, we saw actually, well, we see that lesion on the left, but there's also something on the right in the contralateral prostate, which showed the level of SNR that was, more than noise. We had a certain threshold of 5 and it was above 5, and we thought that something's really going on there. It's not just noise. And then when you take the whole prostate out, you can see that indeed the patient had 2 lesions in their prostate. And that's important because the first really clinical application they can think about is that if you're able to assess the true burden of disease, then you can better identify the patient's suitability for active surveillance or focal therapy. Because these 2 management strategies are often recommended to patients with well-defined solitary lesions. And there's multiple lesions in the prostate, you wouldn't normally go for these things. And then if we can do it with hyperpolarized MR, but not with proton MR, then that's good. Well, you may ask, well, maybe that was just one example here. Well, not really. So those 10 patients, we had 11 lesions that we picked up on standard MR. So most of these patients were patients with single PIRADS 5 disease. And then 4 of those were actually identified retrospectively on hyperpolarized MR and correlated to surgery. So we didn't really see a lactate signal anywhere else but the tumor tissue, which is reassuring, albeit in a relatively small cohort. Well, now the other thing that you can instantly see is that the lesion that is more aggressive, whether it's grade 3 disease, shows a lot more lactate labeling compared to smaller and very grade group 1 disease, which is a Gleason 3+3, that is not even considered clinically significant cancer. Well, can we then use that to sort of substratify those intermediate risk lesions that is such a clinical challenge these days? Well, we looked at those different correlations that they can draw up and saw that there was indeed a significant one between lactate SNR and the percentage Gleason pattern for disease, which is indeed a marker that distinguishes intermediate risk tumors with favorable and unfavorable prognosis. And again, this specific marker is used for stratifying patients that are suitable or unsuitable for active surveillance, and being able to visualize it at the level of the whole lesion rather than in a couple of biopsy cores can help you make better decisions based on that parameters. But then again, you can say, well, it's just 10 patients. Well, all these correlations can be a bit random. Is it just cellularity? Is it tumor volume? Is it perfusion or permeability or whatever? Is it just by chance? Well, if you look at the ADC as your measure of cellularity, then in fact, you also see a strong negative correlation, which might explain, yeah, well, that's it. Well, on the next slide, I'll explain why it's not necessarily so simple. But then if you look at K-trans as, relatively crude, I agree, metric of perfusion and permeability, and here we showed really no relationship between the 2 parameters. So probably that's not simply how much pyruvate you inject into that lesion. So being mindful of time, I won't focus on that a lot, but just to explain to you why it's not about cellularity as a whole, I'll just visualize this. So there's a schema of metabolism in the 2 main cellular compartments in both benign and malignant prostate. Is the epithelial cells on top and the stromal cells in the bottom. And these cells have different types of receptors on them. So we know that pyruvate enters the cell through MCT1, which is this receptor over here. And the thing is that MCT1 is exclusively expressed on the epithelium rather than in the stroma. And then what we also showed that if you correlate the number of stromal cells, the number of epithelial cells with lactate SNR, you'll see a very strong correlation between epithelium and nothing really with the stroma. So what we're imaging is not just crude cellularity, which is measured by the ADC, but especially epithelial cell density or tumor cell density, which is a bit more meaningful. Then the other important parameter here is MCT4. So MCT4 is something through which lactate exits the cell. And normally in cells that are particularly glycolytic, you need a lot more MCT4 than those that are oxidative, because you need to get rid of the abundant lactate, which would normally have a cytotoxic effect. So you would think that more glycolytic tumors will exhibit more MCT4 than the stromal cells. Well, then you have the enzymes, lactate dehydrogenase and its two subunits, LDHA and LDHB, that could also explain the difference in lactate labeling between less aggressive and more aggressive intermediate risk lesions. And then you also have pyruvate dehydrogenase, which is an enzyme that is responsible for another intracellular fate of pyruvate, which is conversion to acetyl-CoA in the mitochondria to maintain the function of the TCA cycle. So effectively, the balance between LDH and PDH might show in which way you go and how much lactate you actually see. So if we look at the MCT1, and we break the tumors by percentage pattern 4, so more or less 10%, which is used for triaging patients for active surveillance, you'll see that there's not really significant difference. Well, there is some, but probably not significant because of the sample size. However, if you look at MCT4, so as expected, you see that there is a significant increase that is driven by the increase in the epithelial compartment. So indeed, this can serve as an indirect evidence for the fact that there's more lactate forming in those more aggressive tumors, so therefore you need more MCT4 in the epithelial cells to get rid of them. Then, if you look at LDHA, and with LDHB it will be slightly different, LDHA goes up in the more aggressive lesions, and then PDHA1 goes down. And the ratio between the two will go up, which again is consistent with higher lactate labeling that we're observing on hyperpolarized MR. So now we can say, well, look, it's probably not just some random clinical correlation, but it has some biological meaning, some biological explanation behind that. So then, all right, so we diagnosed that it's probably tiger or a pussycat, but we really need to confirm this with biopsy. We can't really get away from not performing a biopsy in any patient that has suspected prostate cancer. Well, then the question for us is, how do we best target biopsy? How do we best navigate it? And as soon as we had the whole mount prostatectomy data, we decided to have a look at whether looking at the metabolic map of a tumor can help us target biopsies towards the more glycolytic, i.e. more aggressive parts of these lesions. So you can label tumors based on whole mount pathology, well, but then you can no longer biopsy it, so that's kind of the ground truth, if you like. You can then outline tumors on anatomical imaging, which is the current clinical standard of how we target those biopsies, or you can draw regions of interest around the metabolic map of a tumor with a total carbon SNR at a certain threshold that we think gives you a meaningful signal and not just noise. And then what we did was just overlay all these measurements on the RNA-scope transcriptomic map and see how these ROIs relate in terms of giving you the epithelial density of total lactate dehydrogenase, which, as we remember, did correlate significantly with lactate SNR seen on imaging, and indeed was higher in more aggressive lesions. So first of all, it's clear that the smaller the ROI, the closer it is to where the signal comes from. So when you have this orange metabolically guided ROI, you get significantly higher signal, but that's not entirely unexpected. But then if you look at the epithelial LDH density that you get when you overlay those different ROIs on the actual tumors, you can see that, well, not dramatically, but still, a bit higher in the ROIs that you draw using the metabolic mapping. So from that, we can at least assume that hyperpolarized MR could be used to target prostate biopsy to navigate them towards that glycolytic tumor core that may best represent the more aggressive component of that disease. Well, and then finally, you're saying, all right, well, what about the outcomes? Well, how does it change the outcome? How does it change patient prognosis and the actual management? Well, a few years have passed since the study was initiated, and we got some follow-up data in these patients. So in some of these patients, our imaging initially failed. We didn't really achieve good SNR, so we excluded them from this particular analysis. We'll try to salvage them in the future, but at this stage, we just don't have it. And here we included data from 7 target lesions of the patients we had in the cohort. So if you look at the EAU risk group, which does not include any imaging data in it, so all of them were classified as intermediate risk of biochemical recurrence. And if you look at the recent classification that includes MR, one of those BCR positive patients actually high risk because he had suspicious T3A disease, extracapsular extension. If you look at the final Gleason score from pathology, there's not really much difference. If you look at the final pathology stage, well, actually, there are more cases with locally advanced disease percentage-wise in patients who did not experience BCR, albeit yet did not experience. And then if you look at surgical margins, again, well, you wouldn't really be able to tell the difference between the two if you were looking at these patients prospectively. So then, interestingly, if we look at the ADC as a standard clinical measure of aggressiveness, we can't really spot the difference between the two groups. They overlap a lot. But if we look at lactate between the two types of tumors, we see that there's absolutely no overlap between these values, albeit in a very small sample size. And the same goes to the tissue-derived levels of epithelial glycolytic metabolism. So LDHA to PDHA1, MCT1, MCT4 ratio in the epithelium and stromal cells, they're all much higher in lesions who went on to show biochemical recurrence. And that's just the example above the patient who did show BCR and below the one who didn't. If you looked at standard MR, they would look pretty similar. They'll be both classified in the same way, but then they harbored very different disease, and biologically it shows very different profile. And then that's what we think is happening. So in the BCR positive tumors are largely glycolytic, whereas BCR negative tumor would still harbor some traces of oxidative metabolism, and therefore your pyruvate that you inject will go into the mitochondria rather than being traversed into lactate. And then finally, you can say, well, it's just from 7 patients, that's not much. Well, but then if you look at the TCGA data, which comes from around 400 patients, then you can see that the high expressors of LDHA show much faster biochemical recurrence. And then those with high MCT1 receptors also are more likely to experience biochemical recurrence. And that comes from hundreds of patients. So it has some prominence in that area as well. So what's the future? The future is working with AstraZeneca now to look into spatial omics technology to really understand prostate metabolism a little bit better. From the benign prostate to low risk, intermediate risk, and high risk, and all the individual cell types, epithelial, stroma, all types of immune cells, and actually draw the metabologenomic atlas of the human prostate, and then perhaps identify more promising metabolic targets that can differentiate different disease subtypes, because maybe lactate is not the best one, and that could inform future studies with molecular imaging here. The other thing is to try and test the utility of this technique as a hormone therapy response biomarker. We know that with standard of care MR, it's very challenging to assess prostate that has been ablated, and probably detecting residual cells that are still metabolically different from the normal cells could be the way forward here. And then finally, we're also working on developing alternative imaging techniques such as deuterium metabolic imaging, led by Josh Kagi in the department, which can give us complementary information, but maybe a bit more easy to roll out at a larger scale than hyperpolarized MR. Well, last but not least, just to quickly highlight the other work that's done in the department using hyperpolarized MR. So hyperpolarized MR research here is led by Ferdy Gallagher, as you know, and Ramona has led some world-class work in breast cancer, again, metabolically profiling the disease, looking at treatment response. Then Stefano Sprunk did his PhD with us, and now this is picked up by Ines Horvat-Menich, working in kidney cancer, where the challenge is to differentiate benign from malignant lesions. And then Fulvio Zicania, who did a PhD with us and has now come back as a consultant neuroradiologist, looked at the technique in the brain. And the overall vision for especially BRC4 that launched today was to combine that academic and clinical excellence and the infrastructure that we have to hopefully benefit patients with this technology. So with that, I'd like to thank you all, and particularly Tristan as my supervisor for enabling all this work to happen. Thanks very much.